Welcome back to the Physician's Guide to Doctoring. On this week's episode, we have a guest host, so please be the same respectful audience you are for me and enjoy. Hey, this is Brad Block, host of the Physician's Guide to Doctoring. This is a personal and professional development podcast for physicians where we have experts on the show that try to teach us everything we should have been learning while we were memorizing Krebs cycle. Hey there, it's Brad. As someone who's passionate about podcasting, I've always thought there should be more support for physicians who want to share their stories and expertise. That's why we're launching Doctor Podcast Network.
We're bringing together a community of physician podcasters with one goal in mind: to provide the tools, connections, and resources you need to grow your show. So whether you've been podcasting for a while or maybe you're just starting, we've designed this network to support you every step of the way, and we're going to help each other rise, not compete.
If this sounds like something you'd benefit from, we'd love for you to join us as we get closer to launch. So you can sign up at drpodcastnetwork.co for early access. Stay tuned for more details in the coming weeks. Really looking forward to what we can create together. Doctor Podcast Network, where doctors podcast.
Doctor Podcast Network, where doctors podcast.
Doctor Podcast Network, where doctors podcast.
Hello and welcome to another episode of the Physician's Guide to Doctoring. I'm your host, Dr. Amna Shabbir, and today we have a very special guest. Dr. Joe Sherman is a pediatrician, professional development coach, and consultant to physicians and healthcare organizations in the areas of provider well-being, leadership, and career discernment. His services include coaching, medical team support, retreat facilitation, and public speaking. He's a trained facilitator with the Center for Courage and Renewal and a master certified physician development coach with the Physician Coaching Institute. Dr. Sherman has been in pediatric practice for over 35 years, concentrating on healthcare delivery to underserved and medically complex children in the District of Columbia, Tacoma, Seattle, Uganda, Bolivia. He has held numerous faculty positions and is currently Clinical Associate Professor of Pediatrics at the University of Washington. Welcome to the show, Dr. Sherman.
Thank you so much. Thanks for having me. I appreciate it.
Absolutely. So I had this conversation with you before we started recording. I inquired about the topic you wanted to discuss today, and you chose, I'll quote, Men in Medicine, How Medical Training Combined with Societal Norms Causes Male Physicians to Suffer. Why did you choose this topic?
Probably not a real popular topic, I would say, especially since it's been my experience and there is quite a bit written about the struggle of women in medicine and all of the discrimination, abuse, and struggles and challenges that they face. And so therefore, there are many programs and supports for women. And I would say probably that if there were women listening right now, female physicians who have suffered from the institutional traditions of all that is bad about our medical training system and everything, if they were to say, what is this all about? I'm turning it off. I wouldn't blame them. However, I would also say that I believe that the key to changing the culture of medical training, as well as the culture of healthcare, from being one of a male-dominated, paternalistic, misogynistic culture to one that is more open and actually led by women, then we need to work on the men. We need to try to focus on men and male physicians and help support them.
We're all hurting, I feel. As a woman, I can definitely say that if we have to enact change, it has to come from both parties being present and recognizing what is happening. So I am curious to know if you can share some of your own experiences that really drew you now in helping in creating support and through the lens of a male physician.
Sure. First of all, I have to say that I am a pediatrician. Fortunately, in pediatrics, we're dominated by women now, which gives us a more compassionate approach, I believe, both to our training as well as the culture that exists within pediatrics. And that was challenging for me because I went through medical school. And of course, all of my attendings, usually male, from all other specialties, surgery and all of the subspecialties, they were like looking at me like, pediatrics? Why would you do pediatrics? You're so bright, you're so talented, you're so whatever it might be. And for me, that was great injustice to me, and not recognizing or seeing who I am and why I love kids, why I want to work with kids, and then why I want to be a pediatrician. And so also, I would say that I grew up in a pretty male-dominated family. I grew up with all the societal norms of the expectations of males in our society. And I would say in retrospect, I suffered from that. I think that as I look back, I was a pretty sensitive kid growing up. And the lack of a space to express those emotions, I feel probably impacted me quite a bit. So I would say that's just kind of one window into my own story, as well as why I think it's so important to address this.
You pointed out something very interesting there when you said that everyone looked at you and they said, why pediatrics? And as if I can relate on a different level when I wanted to start as a primary care physician. And I would always show up 100% at every of my subspecialty rotations. So there was sometimes confusion among the attendings, like maybe she wants to do cardiology, maybe she wants to do pulmonology. And when I would say, no, I want to do primary care, I have had attendings just say, what a shame, because you could be so good at this. And I think that's some of our preconceived biases, the way they show up. But it's very interesting, as you point out, that you didn't have the space to process and express your emotions because you were growing up, the training and the people that you were surrounded with, your lens through which you were viewing was primarily male dominated.
Yes. And I would say that one story I remember so well is when I was a pediatric intern, and one of my first patients, my first rotation was in the pediatric ICU. And I had a patient who had congenital HIV. And this was before we even used the term HIV. It was AIDS caused by what then was known as the HTLV3 virus. And we really didn't know much about the transmission or the risk. I was the intern. I was the one that would put on full isolation gear, top to bottom, to go in to draw blood, do procedures on this little 2-year-old child who was dying. And we didn't have any medications to treat the child. And so I got to know the family. I got to know this little girl. And I remember coming in one day as an intern in the morning, and we were on rounds, and I was pre-rounding, going around trying to check on all my patients, and she wasn't there. And I went up to my attending and I said, where's Aisha? And they said, oh, yeah, Aisha died last night. And it was said just like in passing. That was expected, and that's what happened. And I had to walk out of the unit. I went to the only place that I knew that I could be alone. I went to the hospital chapel, and I sat and I just cried and cried, because this little girl and this family had been through so much. And for me, my heart went out to them, and I was impacted by that tremendously. And yet I couldn't express that to my attending. I couldn't express that to anyone there. I couldn't express it even to my fellow residents, especially male residents, because medical culture, we were not supposed to express emotion. In male US society, we're not supposed to express emotion unless it's anger, unless it's something that is competition, anger, rage, those types of things. But crying, hurt, sorrow, sadness, passion, things like that. So I took care of myself, buried it in, moved on the rest of the day.
I can see your eyes tear up as you were just mentioning her name right now. And any one of us who ever loses a patient, it leaves an impact on you. It's never easy. And that second victim phenomenon is really prevalent, and we don't talk about it enough. Being in that place at that time, I can absolutely empathize how challenging that must be. And drawing attention to the fact that rage is acceptable, but tears are not welcome at that time. I want to hold space for that because I definitely have noticed that in the male physicians in my family. And when we talk about, there are definitely injustices that are happening across the board, right? Whether we're talking about women, marginalized communities, everyone in medicine is suffering on their own levels and tiers. And yet, how are we creating places and spaces for accepting that? So I want to draw attention to some of the things that you've mentioned. You're a coach, you're a facilitator. How can we create spaces for male physicians now on a more optimistic note to create that space for processing and welcoming all of this in? What have you seen? First, maybe I should backtrack a little bit. What have you seen shift and how can we create more shifts? Because there's not enough.
Yeah, I think first of all, just to reinforce where this is all coming from, and to be a male in society, at least in the US, I would say, and I spent quite a bit of time living in both Uganda as well as Bolivia, and the expectations of males and the dominance of paternalism in those societies and cultures are similar. But I would not, since I was only a visitor, I can't comment, and I don't want to criticize those cultures because I don't have any right to. But in our society, I can say that for growing up, the message I received and most males receive is you're not supposed to express emotion. You're not even supposed to feel emotion other than anger, rage, perhaps. The other thing is that if you do, there's something wrong with you. You're a sissy, you're excluded, you're weak. The other thing is if you do feel these feelings, you just suffer in silence. I remember as a kid just walking away if something impacted me and crying in the corner and saying, yeah, I'm fine, I'm good. Fake it till you make it. Everything's okay. And then you think about physician culture and what we're expected in physician culture. Never show weakness, keep your emotions to yourself, self-sacrifice, provider, you're the one that takes responsibility. All of this parallels and reinforces what I learned as a male growing up. Always have the answer. If you don't have the answer, you're wrong. And there is this kind of unapologetic paternalism that exists. And so from what I witness is that I saw definitely my female colleagues being responsible for everything as a doctor, and then being responsible for most of what happens at home with kids, family, things like that. This was really emphasized during the pandemic, where it was shown that female physicians suffered disproportionately during that time. So for me as a coach, when I began coaching physicians, all of my clients were women in the beginning. Now, why was that? My suspicion is, number one, women are more comfortable expressing their feelings and emotions and being vulnerable than men. Now, I say these huge generalizations, and I have that kind of like feminine side of me, whatever that might entail to whoever is listening. The other thing is reaching out for help, trying to create community and relationship. These are things that in our society are actually promoted and cultivated in little girls and women as they grow up. All of these things serve women in medicine. They serve women when we are all challenged as healthcare providers. So all of a sudden, I'm a coach and all of the women, and they said, I'm coming for help. I am willing to be vulnerable. These are the things I'm struggling with and can make great progress. And then gradually I started to have more male clients, and it became, okay, I have to be careful here because I have to be culturally sensitive to what is acceptable to them. And if I want to gain their trust and confidence, then I may have to banter a little bit in the beginning. Oh, let's do acceptable talk among men about sports or about what your patients are doing, what are the scientific challenges. So we can't dive deeply into the emotional experiences. We have to take it easy. But then once I'm able to break that tough exterior, then we can make great progress in admitting to our challenges and being open to understand ourselves and what we can do to help ourselves try to actually be more present, be more natural, be more authentic, and be ourselves in medicine.
I have a lot of thoughts coming to me right now as I hear you share that. First of all, yes, I will want to openly acknowledge that for this episode, we are making a lot of generalizations as we're picking on groups. But why is it so difficult for men in medicine to be vulnerable? And yes, there are larger social cultural themes of it as well. But in your opinion, 'cause I have not had that lived experience. And I'm also thinking of what Brene Brown says in her book, Daring Greatly, with regards to her research surrounding shame and vulnerability. And we we're talking about men. So I would love to hear your thoughts on that. And adding another comment to that, because one of the wonderful physicians I connected with on LinkedIn, Dr. Michael Hirsch, like one of his presentations was titled, "Where are all the male physicians?" And I have had people ask me specifically, are you just coaching women physicians, male, like across the board? I'm like, I'm trying to help everyone in healthcare. I am not at this time narrowing anyone in specific, but I have had a general discomfort when I am initially having that conversation. There's almost like this fear attached. If I let my guard down, like what's going to happen?
It's so fascinating because, like I say, in the beginning of my coaching career, all of my clients were female. And then when I started to have more male clients, I was intimidated. I went back to those moments in medical school where I was put on the spot and I was, what's the matter with you, son? Don't you know anything? Don't you go? You get all your information, but you can't put it together. You'll never make a good doctor. What's your problem? This kind of thing.
Yeah.
And then hearing that on the wards, that takes me back to childhood. Hearing that from my baseball coach, from my football coach, from my teacher, whatever it might be. And it's the same experience over and over again. And I would venture to say that if you were to ask women about their experience during medical training and about their male medical student colleagues, resident mates, how were they treated compared to how the women and the female physicians were treated, students? The men were accepted. The men could do men things and were given preferential treatment. And I've seen that. I saw that across the board. But that does us a disservice. It does us a disservice because the expectations are that is going to continue all the way through. And now I have this whole group of male physician clients in coaching that have encountered cultures that are changing in society and as well as in medicine, where women in traditional kind of female roles in healthcare, such as in nursing or nurse practitioners or even administrators, because in business, women are starting to take a larger role. All of a sudden, these males are like, somebody changed the rules. All of a sudden, people aren't bowing over. People aren't doing what I tell them to do. People aren't just saying, oh, whatever you need, Dr. Sherman, sure, I'll get that for you. And I don't know how to deal with it. And so what happens? What I was role modeled in residency and medical school is you scream, you yell, you throw things.
Yeah.
And that worked for them. So let me try that. And then I get in trouble. I get brought up before the medical executive committee or the peer review, whatever it is. And all of a sudden I find myself in coaching to try to fix me. And for me, there's this whole armamentarium of tools that we're not given. We're only given half the instruction booklet. And that's all we need to get through. As a matter of fact, if we only use that section, we're actually going to be rewarded for it. But eventually leads to our downfall until we're able to admit to our own emotions, admit to our own emotional needs, and say that we're not the strong superhero that can do it all and take care of everybody and then suffer in silence because we don't know what to do with those emotions, then we suffer and we continue to suffer. So for me, as I work with male physician clients in coaching, for me, eventually, no matter how I start, and a lot of times I start just by listening. Oh, they did this to me and then they did this. And it's never been that way before. What's the matter with this medical culture? They don't really understand doctors anymore. And then I listen and I go, oh, this is terrible. I'm sorry. Because I can empathize. I know what's really going on underneath. And then eventually we get to all the emotional intelligence work. We get to all the work of what's really happening inside of you. And just get through that tough external, that armor that's there, and try to get underneath. And I've had my male clients in tears sometimes, and all of a sudden understanding why people are reacting and responding the same way, and can make amazing progress.
We really have to focus on all that toxicity. That's the word that kept coming up to my mind. I was hearing you speak. Have you in your experience noticed a generational presence with the clients that you've had, early career, mid or senior career male physicians? Is this worse? I'm going to again stereotype and generalize here. Is this worse in the older physicians, more senior physicians, that they are struggling with this overall shift in medical culture, and that shift can't come quick enough? I can say that from the standpoint of a woman physician of color, but I would love to hear your thoughts on generational changes that you might be noticing.
It's interesting because I notice this in clinical work. I notice this in my coaching, in groups. Especially, I notice it in comments on, say, Doximity or LinkedIn or whatever. And you'll have the older male senior physicians saying, oh, it's not like it used to be. These young millennials are just out for themselves. They don't really care about other people. Well, the reality is society has shifted, and society is moving toward increasing equality and equity. At least it has been. Let's hope we don't slip back. And so, as a result, I believe that there are senior physicians who have been brought up into a culture. That's what they learned. That's all they know to survive and to move through. And so, therefore, it becomes embedded in them. That behavior, especially if it's reinforced by those parts of them that have taken over and have actually been successful, that becomes the dominant behavior. And what is happening now in medical school, in society, is that men are becoming more aware of their emotions, that from young ages, this actual gender dichotomy is all of a sudden not there as much anymore. I can tell you for my own kids in their 20s, the whole idea of male, female, men, women, things like that, it's all relative to them. And we are seeing a shift. And I would say that more senior physicians may be holding on to this culture a little bit more, especially if it's been associated with power and control. If they run into situations where behavior like that doesn't lead to power and control, but instead leads to challenges, getting in trouble, being sent to a coach to fix you or whatever it might be, then all of a sudden they're confused. They don't understand. But I would say that younger male physicians, because of society changes, those young male physicians are still exposed to the old timers in training. So if your attending is expecting a certain type of behavior and rewards you for that, then that's the behavior that you start to pick up. But I would say this, that as in other parts of their lives, especially any intimate relationships, any relationships that they have and that they're trying to navigate, if I as a coach can relate how their relationships in the office space parallels their relationships in their homes, then we can hit home and make some progress.
Interesting. Definitely a shift in societal expectations and thankfully assigned roles being shifting. It's like this concept of trauma transfer that we do from older attendings to younger attendings and medical trainees, which I wish we would just stop, and having tremendous compassion for both sides, for the senior physicians that have had to go through tremendous toxicity, as well as for our upcoming younger physicians and generations of medical learners. So as we look towards the future and in a more positive, optimistic way, you are having those conversations. There are a lot of other amazing physician coaches, and the culture surrounding well-being, at least we're having conversations. It's definitely not permeating everywhere. What are some of the things that we can do on a more organizational level that could potentially shift this balance towards a non-toxic, I'm okay to ask for help culture when it comes to male physicians?
Us physicians in our work. And the key is targeting the senior physicians, targeting those people who have influence, those folks that have influence on the culture, those folks that really make a difference. Because no matter what mindfulness classes and sensitivity, awareness, and things that you kind of classes or workshops you take in the first preclinical years of medical school, when you hit those clinical years and you hit the wards and you're facing that more senior attending and senior resident who learned how to act from that senior attending, then all of a sudden that's all out the window. It's them. They're the ones that make the difference. And for me, that means compassion and empathy, which toward those senior physicians, it's almost as if instead of attacking people who are stuck and have been given this kind of mode of behavior and code of behavior, instead approaching them compassionately and saying, you are suffering. And even as I say that, I can see my wife, my daughter, and everyone's going, what are you saying, Dad? But they are suffering. And if we can have compassion and empathy toward those senior male physicians who don't know an alternative way of behaving, don't know an alternative way of being in relationship, if we are able to first have compassion, acceptance, and understanding, then you build trust. And then I'm able, through a lot of different modalities, especially a modality called internal family systems, just trying to point out different parts of them that were hurt as young kids, like I was as a young kid when I cried and you were saying, you little, whatever it is. So that part of them still exists and still really longs to be expressed. And when I can empathize with them, have compassion, I can speak their language because I came from the same culture. And then I can say, let me tell you what happened to me as I started to just be open to this stuff. And let me tell you how hard it was for me. And then we can start exchanging ideas. We can start trying things. And then all of a sudden perspective changes. And then that trickles down to all the people that they train and that they influence.
What I'm getting at is two things from what you're sharing and my understanding, correct me if I'm wrong. Number one is compassion, and that will build trust. I always talk about compassion across the board, self-compassion and compassion towards other. And that other can be anyone. And that should also include you. And that involves talking to ourselves with kindness. So compassion. And the second thing is experience share. Talking openly, such as you are talking about the difficult experiences that you had from childhood and normalizing that. Whenever I heard any of my senior colleagues openly talk about their challenges, it was such a relief because I felt that I wasn't alone in whatever I was thinking.
Absolutely. And I lived and worked in Bolivia for 4 years and was really away from medicine in the US for that whole time. And then I got a position as medical director, senior physician attending in a clinic in pediatrics. And I walked into an exam room and a mother of a child that had a complex medical condition said, we're still waiting on the microarray test and we're hoping to have it back so we have a better idea about what's going on. And I was listening and I had no clue what microarray meant or what that was. It didn't exist when I had left the country 4 years before. And I went into the attending room, the work room, and I looked around for the youngest person in the room because I knew that's the person who would know. And I looked around and I thought a third-year medical student like trying to melt into the wall. And I called him over and I sat him down and I said, can you tell me what a microarray is? And I just saw his face, just like all the blood rush out of it. And I said, before you even attempt to answer, let me tell you, I have no clue what it is. I've been in Bolivia for 4 years in this tiny village. I have no idea. You would be teaching me. Please tell me what this means. And I can tell you through that exchange, that medical student came alive. He was like, wow, I know something that can be helpful to this old geezer. So that was a breakthrough. And I think if we can have more exchanges of humility like that, then we're going to find that relationships improve, that understanding improves, and that we'll be able to support each other through this healthcare crisis that we're in.
That was a very powerful share. We often forget that we are all on the same side of the table with a common goal to heal our patients and support each other during this time. However, just keeping space for that compassion. Thank you for sharing that. As we wrap up for today, Dr. Sherman, what is one key takeaway that you would want to impart wisdom-wise or maybe more to a male physician listening to this conversation and they're potentially struggling?
I would say that, number one, have the courage to reach out for help. Have the courage to reach out for help. And because there is help there, if it's not through mental health and therapy, it is through coaching or even a friend. And I would also say, have compassion for yourself. This isn't because you're the weakling, because you are the one that couldn't handle it. You are someone who is a human being that's having human emotions. And if you can have some self-compassion and some understanding and to realize that even though we may appear to have this tough exterior that seems to be either sarcastic or angry all the time, inside we are experiencing emotion and we are desperate to try to express it and to share and be in relationship. You're not alone. Please try to find some compassion for yourself and have the courage to ask for help.
That was beautifully shared. How can folks get in touch with you? Any news you want to share with everyone? Love to hear that.
Sure. Thanks so much. You can reach me by email, joe@joeshermanmd.com. So it's my name, joeshermanmd.com, and that is my website, and it's joeshermanmd.com. And if you just search for that, you'll find me and programs that I offer both in one-to-one coaching, individual coaching, as well as group facilitation, retreats, and other programs that are available.
Wonderful. It has been a pleasure talking to you today, Dr. Sherman.
Thanks so much, Amna. I really appreciate the invitation.
Thanks for listening. I have a favor to ask. You listened to the episode until the end, which means you either fell asleep or you really liked the episode. So please share it or like it or comment on a social media post or write us a 5-star review. Something. It would really help me out. And maybe what you learned from this episode can help someone else too. The views expressed in this episode are those of the interviewer and interviewee and don't represent the views of their employer or even their significant other. Even though the magic of podcasting make it sound like I'm talking directly to you. This is not a doctor-patient relationship, and this is not medical advice, or financial advice, or really any advice. Thank us again for listening to The Physician's Guide to Doctoring.